Dr. Gisel Catalan from Filipina Heart Center, Philippines. He will deliver the title of the presentation is Tailoring DORV Repair in Philippines, Timing, Technique, and Outcome. For Dr. Gisel Catalan, the floor is yours.
Good morning to everybody. Thank you for the organizing committee. I'm sure Budi will be the happiest man in the country after this day. So to tell you about what I'm supposed to do is, first of all, maybe a recap of what other distinguished speakers have said yesterday. I probably would not be able to add anything new. I'd like to introduce our patients' journey as far as our country is concerned, what they have to go through in order to get treatment, and some specific technical considerations which are inherent in my country, and of course our outcomes. Well, traditionally the DORVs have been classified anatomically, but lately this is a more proper classification functional, the subaortic VSDs, the fallow type, the TGA types, and the non-committed VSDs. Echocardiographically, there was a previous classification of more than 50%, but that is subjective and arbitrary, where you can have different relationships, and rotational and translational motion can make it difficult to apply this rule. So the basic definition is both great arteries are completely aligned with the RV. Now, the incidence of DORVs, we have more here in East Asia rather than in West Asia in a Korean study. Very rare still. And these are the incidents in this part of the world. The operative risks, of course, for DORV VSDs, less than 5%, a little bit higher for TGAs and tetralogy types. And of course, the remote VSDs are much higher than the previous three. The single ventricle pathway, as was mentioned, of course, has a lower mortality, but as I will probably allude later, has better results in the long term. Management. So VSD closures for subaortic types, fallow type, VSD closure and reconstruction of the RVOT. TGAs, arterial switches are done, and non-committed, whether it be a single or a biventricular approach. Management, of course, you can have initial palliation with banding or BTS, and definitive surgery. The biventricular repair overall has an 86% survival, and you do have a option of doing the pathway, the Fontan or the single ventricle pathway. These have been helpful. It's about 37 years, this paper, but more or less as a guide is the distance between your pulmonary valve and tricuspid. If you can really create a tunnel or a pathway to the aortic valve from the VSDs. If it is much shorter or there is obstruction because of those two structures, then probably you should consider a more complex biventricular repair or a single ventricle pathway. Now, biventricular, you can create a tunnel, or you do the arterial switch, usually done at about 3 to 4 months, and so with doubly committed VSDs at 4 to 6 months. Now, the criteria for biventricular repair, this is for actually a single ventricle. As was mentioned yesterday, you should have 2 good ventricles, and you also have relative criteria, straddling, etc. Now, long term, of course, if you do choose to do the complex biventricular repairs, you just watch out for tunnel obstructions. And generally, the reoperation rate for DORV is about 20%. Now, this was in a recent webinar. Professor Lacugaye, why engage in a challenging biventricular repair when the Fontan probably has lower mortality? His answer was basically the long-term outcomes of Fontan, as we know now, as the Fontans get older, is generally not good and ultimately requires heart transplantation. This is food for thought for us, but as what was mentioned by Professor Kim, it should be individualized to the institution, to your country, and more so to your patients. The the prospect of reoperations and the difficulty for the family as well should always be taken into consideration. Just a short video. I'm sorry I wasn't able to get my own video. I had some technical issues. I just pulled this out. It's a tunnel. That's the suturing beneath the tricuspid valve. Generally use a Dacron valve, which we also use because we like the curvature. And that's just about it, just closing it. Short video. Now, about our country, the Philippines, we have about 110 million people, which is quite a lot, but I'm sure Indonesia has twice more the number. We have about 7,600 islands. Indonesia has 10,000 more. It has become an issue as far as delivering healthcare in open heart surgery for congenital cases. We have about 18 regions. 18 of these regions are open heart capable. We have 4 regional referral centers for pediatric care. Down south and in the middle, in the Visayas and the mainland, which is the center in Manila. My own institution is the Philippine Heart Center. It's only a 450-bed government-owned corporation, and it's a specialty apex dealing with hearts only. We do about 1,000 pump cases a year annually. And generally what we have is if a patient comes in, there are only 2 options, whether it's a free patient or as a private patient. But we do have an improved government insurance system, but they only take good risks for TOF and VSDs. More complex cases are not taking care of that. And these good cases, they can be operated on for free. And they can also subsidize private patients. So generally, the number of patients operated on is 1:3, free patients to private patients. So on the average, sadly, in my country, it's 50% out of pocket. There are about 15 surgeons in the entire country. So there's really a maldistribution, 1:1 million surgeons for the entire country. But we do aim to, and then most of these surgeons are located in urban centers. Referral system, I'm sure it's the same. They go to a local health center, pediatrician, pediatric cardiology, and ultimately to a cardiac center. But for 100 million people, the queue, of course, is very, very long. So the challenges are geographic, language, and financing, as what I mentioned a while ago. Access to specialized care, capable specialized centers, of which there are only 1, 2, or 3 in the entire country, and few cardiac surgeons, and mostly in the urban center. We do have patches, but our PTFE is in very poor supply, so we have to look for others. And Contigras, we do, but of course it doesn't last very long. We usually make composite grafts. We do have ECMO. We have no homographs, we have to import. We have done LVAD, RVADs, but of course it's a big financial undertaking for my country, and we are trying to revive transplantation as well. So institutional outcomes for the biventricular repairs, we've done about 118 for the past 10 years, about 10% mortality. Single ventricle approach, 56, lower of course, 3.6 mortality. So overall, about 174 patients, about 8% for all DORVs. If you include palliation, about 255, and it goes up to about 11% mortality, which includes BTS and PA banding, which is ironically, of course, a lot more risky for patients. These are my references, and I do want to invite you to our country this November. Thank you very much for your time.
Thank you very much for Dr. Gisel Catalan.